All right, everyone. Welcome to July's episode of Rising Stars. I'm your host, Jessica Assefa, and today we are going to talk about all things HOS. Before we get into that, just wanted to mention too, one thing I really love about this podcast is what it brings from just a tactical, practical perspective every day for how to operationalize stars. I see CMS will drop a bomb and we all, myself included, put a million articles out there and thought pieces, or there'll be a lawsuit, for example, right? And everyone's out there, including mine, go read my articles on the recent lawsuits. And that's great, right? It's important. We need to know what's happening. But I think sometimes we can get distracted by that. And we miss kind of that everyday tactical, practical work and advice to help us excel in stars that we need. And I think that's some of the value that this Rising Stars podcast brings. So in the spirit of that, and with HOS in the field, I thought we would jump in and talk about that a little bit. Before we do, I'm so excited about our guests today. We're going to have them introduce themselves in a moment, but we've got Yaun and Becky Dube, two leaders at Ganey's Star Center of Excellence, who bring just a wealth of experience and deep knowledge and expertise to the star space and the HOS space. And I'm just thrilled to bring them on and introduce them all to you today. So without further ado, I'm going to pass it to you, Caroline, to tell folks a little bit about who you are.
Sure thing. Great to be here, Jessica. Excited about this conversation. Hi, everybody. I'm Yaun, and I'm Vice President, Senior Principal of Star Center of Excellence here at Ganey. As Jessica was building out our department, it was important to her to embed SNP expertise into our team because, SNP is the only growing area of Medicare Advantage, as we know, and makes up a whopping 18% of the Medicare Advantage book. So with that, we need, to have someone who can speak to the special considerations that are all things SNP. And we'll be talking about that a little bit later on. I've led various SNP plans in many capacities for national and regional carriers, and look forward to our conversation today. Becky?
Hi, I'm Becky Dube. Great to be with you today and excited to have a conversation about all things health outcomes survey and just health outcomes in general. I feel like this is an area that oftentimes we don't kind of dive into as deeply as stars and health plan leaders, and so excited to talk through that. I am a pharmacist by background, started out my career with a little bit of retail pharmacy under my belt, and then quickly moved into the managed care space where I worked in the PBM environment for a short time, and then worked in a health plan that also had a provider group that was affiliated with it for about 15 years. Was able to really start a Medicare Advantage plan with a number of other great leaders from the ground up, first focusing on Part D, and then building their end-to-end star ratings program. And then spent some time during my time there kind of moving through a number of the operational and clinical functions of the health plan, leading everything from care management to member services and Medicare bids and product development. And then spent the last 6 years of my career prior to coming to Ganey a year ago in a health system where I led their accountable care organization and value-based contract performance, especially in the Medicare Advantage space. There was a lot of that developing, but also with commercial and Medicaid lines of business as well. Also had the opportunity as I was leading that to lead their primary care operations and really dig in with providers on a number of these care processes that help to support things like health outcomes and preventive care and screenings. And then also spent some time leading some inpatient and outpatient pharmacy functions and really helping to integrate pharmacy into the care models. So super happy to be with you today. And Jessica, I'll turn it back to you.
Yeah, sounds good. So we have the big brains at the table today, folks. I'm excited to dig in. Before we, get in and kind of talk about some, what can we do to move the needle on HOS, just wanted to acknowledge, I know we probably have folks on the line, quality leaders and stars leaders at all different places in their career and with different places in their level of understanding. And just wanted to acknowledge a pain point for those of us that have been in stars for a long time, and maybe something new for those that just entered, but the crazy timeline that is HOS, right? And what really, part of one of the many things that sets HOS apart is really a unique measure domain within stars. So the HOS surveys, 2 of them, a baseline and follow-up, that are in the field right now in calendar year 2026, the outcomes of these surveys are going to impact those 3 single-weighted measures, right? So falls, bladder control, physical activity for star year 2028. But they're also going to impact those 2 triple-weighted HOS outcomes measures, improving mental health and improving physical health for star year 2030. And so we're impacting 2 star years very far down the timeline. And remember, the payment for that is even a year later. So I think it's just so important to understand that, to recognize that, and to acknowledge that, and to understand that although stars is a long game, HOS is an even longer game within the star schema. So that's not new. That's been around since the beginning of stars and the entry of HOS. But what is new, I think, is all of the attention on HOS lately, right? I mean, all of a sudden, everyone's sitting up and taking note, and just wanted to dig into that a little bit. I don't know, Caroline or Becky, if one of you want to chat a little bit about why does everyone all of a sudden care so much about HOS?
Sure. I think as we step back and look at all of the proposed rulemaking and the codified rulemaking over the last couple of years, CMS has really been shifting and positioning their focus on health outcomes, on more clinical measures, right, and clinical facets and experience facets of the what has been part of the star rating schema and quality measures. And so as we look at those changes that have been finalized between star year 26 and star year 29, really a big shift, a doubling, over doubling of the weight that HOS is going to carry in that star ratings math and star ratings picture. And so that in and of itself is a reason why HOS is gaining in importance and more time in people's conversations. But also as we think about the struggles that health plans have with financial management, utilization management, trying to control readmissions and look at that financial picture, health outcomes are a big part of that story, right? And how you help your members and patients, if you're a provider, to help to ensure that their disease progression isn't causing them to have more utilization of services if it's not appropriate, or if it can be prevented. So those are 2, in my mind, of the major reasons why HOS really, is amplified and continuing to be amplified in conversations.
I love that you brought up the MLR impact. Managing MLR, right? We're thinking about different things that we would do as health plan leaders, as far as prior authorization, our frequent flyers, the high utilizers that are, to the ED. Yet, all of this goes into, health outcomes and how members consume their health services, as well as, what is the result of that. So not only, does HOS matter more in the STAR schema over time, right, based on these changes, but also with the additional pressure brings in additional focus. That's good.
Yeah, totally. One thing too, when we were chatting earlier, Caroline, I heard you say, and if I heard you say it once, I heard you say it a million times, that HOS is not CAHPS, right? And I think a lot of health plans make that mistake, right, of kind of treating them the same and operationalizing them, or attempting to, the same from a strategic standpoint within plans. Can you dig into that a little more? What you're seeing plans do right, and where you see kind of opportunity to.
Thing. I think again, let's look at this through the SNP lens, all right? Because again, that's my lane, and obviously my favorite. Anyhow, um, so when we think, what I love about the additional focus of HOS now, and then also thinking about who can actually impact HOS. Right. That's when I think about my SNP care managers, care team, the care coordinators, all that entire staff that ends up running that model of care. Because, when we think about HOS and how, we're focused on, our improving falls, right? We're talking about bladder control, we're talking about physical activity. Those are things that, should be identified on our HRA right at intake, and allows our care team immediately to deploy into those conversations they're having with members, the support that they may need, and linking folks with the services that could support them. When we're thinking about, again, very clinical in nature. I mean, that's what HOS
Right.
is, so it's very different. It's an experience like survey, but it has to do with how you experience your health and well-being, and how a member is reporting how they feel over time. So lots of different ways to tuck in to influencing those outcomes and how a member would
Yeah.
answer. Mhm.
Oh, totally agree. I see so many plans, and maybe this works sometimes. I mean, depending on the leader. I don't want to knock everyone's strategy, right? Who's doing it this way, but I see a lot of plans who kind of tuck member experience and HOS under the same leader in the same department because they're both surveys, and missing a lot of what you just said, Caroline. Like this is about health outcomes, right? It's not just about our experience with care delivery. It's about the outcomes of those care delivery measured over time, and really different initiatives. And where I've seen it, and again, it can work the other way depending on the leader, but where I've seen it really operationalized the most effectively is when we have HOS sitting up under clinical leadership, right, within the health plan, under this CMO, CNO type structure within a health plan. Yeah, definitely. I think another common error, or maybe opportunity, if we want to say it that way, opportunity, right? That's the positive way to say it. That I see within health plans is the opportunity to stop working HOS in a silo, right? Where we're like, okay, this is my HEDIS initiative, here's my pharmacy initiatives, and here's my experience, and here's my HOS initiatives. And without really realizing that HOS is almost the ultimate measurement of how effectively you're working every other domain within STARS, right? And sometimes plans will make that connection, folks with some of those HEDIS measures or care transitions measures where there's a little bit more of a clear alignment. One area I think I see folks, and we were chatting about this earlier, kind of missing the mark and the connection point is where HOS meets pharmacy, right? How are we looking at pharmacy and medication utilization in a way that serves almost as a bellwether for HOS outcomes? And Becky, I want to like throw it to you.
Sure. And I joke that I love to say that pharmacy can impact everything, right? So why not HOS? And let's make those connections. But no, truly, I think about it in two ways from a pharmacy connection perspective to HOS and the activities that plans are doing, could be doing to help support HOS. One is more the proactive view. And as you think about what are indicators, right, as a plan that you receive or have access to that can help you understand if your members' health may be declining or becoming more complex. Often you see that picture of complexity being created through utilization, especially pharmacy utilization. It is real-time information, generally the first and most frequently used benefit of many beneficiaries, right, and many members as they're using their pharmacy benefits. And so seeing that complexity picture start to be created. Are they adding, another medication to their diabetes regimen? Are they adding, multiple other chronic condition medications that need to be looked at? Is there some complexity starting to be created in the picture of medications that could create more fall risk or could lead to, some decompensation of a particular condition. So I think really first and foremost, how are you using your pharmacy information and what you know about your members? And it may even be through similar identification criteria that you're building or have been using for your medication therapy management programs as well, right? So looking for those connections and how can you identify earlier on which members may start to see some decline in their physical health or mental health, because we know there's such connection to that complexity and those comorbidities and how members feel about how their health is progressing or is sustaining and maintaining. The other piece, though, is what are the interventions and activities that you are doing, whether it is pharmacy specific or pharmacy in conjunction, hopefully with care management and other programs, right? Jessica mentioned this, but I think it's such an important part of the STARS picture in general and any quality improvement framework. This isn't just about these one-off interventions, right? It's about how do you bring them all together. So if you are looking for things like, are there opportunities for medication optimization for a patient? Can you identify, is someone non-adherent, and when you're reaching out to them or working with your vendors to talk with them about that, you're identifying that there's a side effect that they are experiencing, and that's why they're not taking their medication. That side effect may be making them feel like they're not doing better, right? Or they're not feeling great from a physical health perspective. So understanding those things and making those connections and being able to act on that particular touch point that you've already been making with that member to help potentially improve how they're feeling in that day, but also longer term, I think are all really important places. If you are doing deeper dives into things like, your beers list or your potentially inappropriate medications in older adults list, right, of medications, you can identify those members. Well, yes, there's a falls risk piece to it that you may identify. There's also in general, these are medications that tend to cause more side effects or shouldn't be used in an older population. If you have initiatives like that, those all have great connection to helping to maintain and improve your members' physical health.
Yeah. And that takes, I love all of that. And that it takes me to data flow too, right? How is data flowing across your organization? I mean, here we talked about pharmacy, so we can stick there for a minute, but data in generally that informs HOS strategy, that informs health outcomes. Is your data flowing again in like a siloed fashion? We're giving adherence data to everyone, adherence data to care managers, or are you thinking more broadly than that, right? Or what's that those three classifications of medications that fall into the adherence measures are one thing, but like you're saying, Becky, there's so much more in that Part D space that tells the story of members from a true health outcomes perspective. And are you getting that full picture into the hands of the folks that interact with and call your members, right? Vendors or staff or whomever, getting it into those folks doing MTMs like you're saying, and into care management, right?
And
That
bring
that
them
full
into things
picture.
like risk models, right? How are you
Mhm.
identifying the populations that you're acting on? And so that holistic data view and how you're then bringing it into the activities and actions that you are already doing, right, in many cases. And I think that's often something that we hear from health plans, right? We can't
Yeah.
do another thing, right? Like there's not another thing that we can do. Well, let's look at what you're already doing, right? Because there are likely all of these synergies and opportunities, some of which you may already have the data flow or the interventions identified, some of which you may just need to bring another piece of information in or make it visible, Jessica, like you said,
Yeah.
to your care managers, right? So that when that conversation is happening, those questions can be asked. You can lean into addressing those other items that may pop up for a particular member.
Well, and one of the things that we hear time and time again, just in our consulting work, is we talk about member journey, member experience,
Mm,
all those member touch points. And reliably we hear, oh my gosh, we realize that, our members are getting 30 outreaches or more, right? So the idea is not necessarily we hear plans also go, I can't do another initiative. We don't have the capacity. All the more reason to make sure your care management team, right, really understands HOS. Do an education for the care management teams. Like, help them understand the questions that the members will receive. Help them understand how their work that a lot of times they're already doing actually ties back to this, and would make a difference in the way the member experiences and answers their questions, but also more importantly, their health in general, right? Impacting that.
yes. And yeah, Caroline, and isn't that where like the plan of care too? Like while you're talking, I'm thinking the plan of care, the interactions with the interdisciplinary care team, where these activities, these federally required activities can move from a check the box to a living, breathing document where if that data is flowing to care management that says, okay, this person had just started on diuretics and it's at a pretty high dose or like all of these things, how does that flow into like some of these maybe significant change in status um um assessments that need to happen with our SNP populations, and how can we operationalize that in a way that
I
that
think
really moves the needle for folks?
I think that really it's spotlighting it, okay?
Yeah,
Because as we sort of touched on the HRA, which is of course required, right, at the intake, or enrollment, right, of a DSNP or SNP member, we typically use those documents for triage. Right. That's how I've seen them. I've seen them used, time immediate needs, making sure that members get in and they're supported, obviously, as they enter the plan. I mean, what else do we capture? We ask questions about physical activity, physical and mental health questions. We ask about fall. We ask about urinary incontinence. So those are all things that are captured on the HRA. Should they flow into the individualized care plan, right? Of course they should.
right.
And and have the associated goals with that, and when the care manager is reaching out, those are things that are discussed, again reinforcing, just exactly tying back to HOS. And I think if the care team is educated on HOS in general, right? I think that there are many care teams that are not educated on HOS. I think that kind of
Great.
lives in another department. And when you think about employee engagement, it's very important for folks to know what they're doing matters. We already know as care managers, managing this very vulnerable population, that what we're doing matters to the individual member. We know that. But how does it tie to our business goals, to our health plans, success, and understand that success begets more success, and we can offer better benefits because we're
Right.
completing this, more resources to the members. So, being able to make that connection all around, I think would make a big difference.
And I bet, Caroline, right? I know we've had this experience as we've trained or educated care managers and other clinical teams on HOS. When you educate and you ask a question to a group of frontline care managers, how do you see how your processes today, how your conversations today could help with this? You will get 2 hours of conversation if you would let them, I bet, and even more follow up, right? As people are thinking about it and ruminating on it, because they see the connections. Oh, I remember, member Smith that I talked to yesterday who, brought this up in our conversation. And I wasn't even thinking about this connection to HOS because I didn't understand that, right? And I could have leaned into a conversation about X, Y, or Z. So I think that you put the teams that are talking with these members, right, through the channels and processes that you are discussing in those conversations. They identify very quickly those places that they can lean into, because the clinical connection and that clinical soundness of, well, this is already something that I know is important with this population to be talking about. They immediately go there on their own.
I think so too. And I hope folks have their pens and papers out or their typing fingers, because honestly, guys, this is how you take I can't tell you how many HOS work plans we've looked at that consist of interventions like member newsletter, provider newsletter, tell customer service to increase HOS survey participation. And if you don't have a strategy in place, do you really want to be increasing your HOS survey participation? So, I mean, start thinking about some of the things that this is how you work HOS in a meaningful way, and in the way that CMS really intended, right? When they decided that these measures should be core to star ratings. So that's how we move from member letter to member interventions. There's also provider letters. Like when I see our provider facing HOS strategy, it's the provider newsletter, right? Or these tip sheets that we send out that give a million additional things providers should be doing to move the needle on something that really, from their understanding maybe, and the way we're communicating it, isn't central to what they're there to do with patients. When really HOS and the improving the health and mental outcomes of folks is central to what they should be doing. This is something we were chatting about earlier. Becky or Caroline, I don't know if you want to dig into this a little bit more, but what are some meaningful ways we can partner with our providers to move HOS in a way that amplifies, catalyzes what they're doing versus adds to what they're doing?
Yeah, I think about some of my time in the provider space and health system space, and the moments when a plan would come to me with really good and very nice documents, right, of tip sheets or items to say, like, encourage your providers to talk about urinary incontinence more, or encourage your providers to do depression screenings. And all of those were great, right? But what I had to think about as the person that was trying to bridge, right, and make these things real, and work with our providers on those strategies, were really practically what already happens in the process, the clinical workflow processes, right? Because, Jessica, to your point, this is the work of a provider, right? It is to take care of acute needs, also to ensure that long-term preventive care, prevention of progression, prevention of development of chronic conditions or worsening, right? All of those pieces are part of what clinical care processes are built or should be built to help take care of. And so really taking that step back, right, as you're trying to work with providers and say, what is it already that a provider and their care team, and I'm very specific to say and their care team, right, because it's not just about the impact that the provider themselves can have. It's also about what are the workflows and activities that nurses, MAs, others, pharmacists, right, others that are part of those care processes could be doing to impact. Are you doing depression screenings already, provider A, B, or C? Yes, we are. My MA does it as the patient is roomed. I then look at it, right, as a provider, and I need to decide what is the conversation I need to have with this particular patient or member as they're sitting in front of me, or talk to the nurse or someone else who's going to work with that patient on strategies. What are tools and resources? What follow-up should be happening? Maybe I need to prescribe a medication as I'm talking with that patient. Maybe they need a referral to another provider or a counselor, right? So as we talk about the mental health space, most providers are already doing, or most clinical workflows already have depression screenings, anxiety screenings built into many of those workflows. How can you use that as a jumping off point to say, identification is the first step, right? And then action, and how I engage with the patient and how my care team engages with the patient on that is the second step to helping have the best opportunity to impact how that member feels about and truly is feeling on a daily basis about their mental health in this particular example, right? Similarly, with things like falls risk or physical activity, hopefully we're talking with, as providers and care teams, we're talking with our patients about those things. We're asking those questions. How many times a week do you do physical activity that gets your heart pumping, right? Works up a sweat. Okay, let's talk about what other strategies. Sometimes for a particular patient, it may be today what I can do is walk to my refrigerator, right? Well, maybe a month from now, 2 months from now, what you're able to do is walk to your mailbox, right? If that's just down a path in front of your house. So helping them, it doesn't have to always be huge strategies, but also it can be simple things, right? That particular patient is able to take back and work into their daily work. Similar to what I said about health plans, providers and care teams are saying, I can't do one more thing, right? Please don't come to me with one more thing that you're asking me to do.
Yeah.
I already have a hard time addressing all the items I need to with a patient. And so figuring out where in their workflows and strategies you can help them to support those conversations that are already part of just good evidence-based clinical care are critical ways to approach it.
Love it. First of all, amen
Mhm.
to all of that. And, a couple things I just love about what you're saying right now, Becky. One, it takes our provider strategy from a newsletter and a poster on a waiting room wall, which I'm not saying scrap those things, right? They're
No.
important, but these are baseline. This takes it to like actually embedding it into care delivery the way it was intended to, right? I love that. Love it, love it, love it. I love also how you talk about the follow-up, right? Afterwards, following up with those patients afterwards beyond the care visit. And that can happen from the provider's office, and that can be complemented by outreach from the health plan. This is important twofold, right? One, because we've got those single weighted measures that say not only did it happen, but do you remember it happened? Right. And that's where I'm going to knock on your door, Caroline. You're on my right. I don't know where you are out in the podcast world, but you're to my right. That's where we knock on that care management door and say, okay, you let's pass the baton, you take it here. But with these outcomes measures, it's not, these outcomes measures are so different. These longitudinal measures, they're not, do you remember talking to your doctor about XYZ? That's not what these measures are, right? These measures are about, did your health actually improve from your perspective?
Mhm.
And without those things you were talking about, I love the walk into the mailbox and example you just gave, Becky. I mean, this as a member takes me from measuring my baseline of, I used to be able to go for a 2-mile walk every day, and then I had a stroke and my health is much worse, to saying, I used to be able to only walk to the bathroom, and now I can go all the way to my mailbox and my health is improving, right? That's HOS. That's HOS, yeah. How might care management pick that up, Caroline? Like within the health plan, like when I talk about passing the baton over, helping members remember and continuing that improvement partnership with providers.
Thank you for asking about that part, because as Becky was talking about what the providers can do, what was in my mind was that provider care team partnership that we always stress so heavily when it comes to the SNP population, right? And we're thinking about tactical tips that we can give here, and that is having a referral mechanism from your providers into your clinical care teams. That's absolutely critical. You can do it lots of different ways. You can just simply have a secure email box that members are sent over and someone is triaging it. I know that a lot of times our care management teams are not staffed to be an incoming call center, so having somebody who's able to watch that triage box and get back to folks. But there's also an opportunity to reinforce so many of these things, right? And that's where we see a divergence, right, with the general MA population and how the SNP population performs on some of these measures. We brought that forward. Would you like for me to show
Let's do.
some stats?
I
It's
think
pretty
this is
cool.
really interesting.
Yeah, it's pretty cool. All right, let
You know,
me.
as you're digging through that, there, if any of you want to do a little research on your own, the SNP Alliance did, tons of great research and provided insight around performance disparities between duals and non-duals and how that may not play out equally in stars and in HOS, and we did the same. And Caroline, please do talk a little bit about the
Sure
work
thing.
that we've done here.
Yeah, let's just go ahead and walk through the slides. So you can see here what we did was we compared contracts that had 0% DSNP and 100% DSNP, just to sort of, and obviously we know that there's a continuum, but this gives us a nice snapshot. And what was interesting is that we can see here that for both mental health and physical health, these triple weighted, outcomes measures, we've got the SNP population performed about half a star lower. The reason is with this was sort of a surprise for me because we've been thinking a lot about how this membership is risk adjusted, and so what this tells us is that a risk adjustment doesn't really absorb the difference here. Um, something to think about. And as far as our being able, to work with members and make sure that they're getting the support that they need, and access to the services that they need through our care managers. But look at this, you guys. When we go to the process measures, you can see physical activity is flat. And I was thinking about this that, we looked at DSNP, and I think we're going to have an opportunity with all the CSNP growth to see if, we're going to have very concentrated care management for those members. Think about it. The biggest growing segment of CSNP is this cardiometabolic CSNPs. So it would
Yeah.
make sense that there's going to be a lot of reinforcement with physical activity. So I wonder, can we read the tea leaves, right? And think maybe we're going to see a bump here. It's pretty flat, but I'm thinking we're going to see some positive trend. If, and I can't wait to talk about it, upcoming and see if we're right. Then you can see too that both bladder and falls, the DSNP members perform better than the general enrollment, particularly falls 2 full points ahead. And that just shows, model of care is working, right? Interacting with the members, reinforcing these behaviors and interventions and access to them. These are things that you talk about with your care manager, particularly fall. A lot of benefits around fall prevention. I know that was things that, those were supports that I put on my plans as far as, different supports and access to different benefits that would support the members.
Yeah. This is just such a great look. And I love kind of that little tease you gave about how with the growth of these CSNP contracts we're seeing, are we going to see that play out in these outcomes measures? I hope so too, Caroline. And I think whether it does or not really heavily depends on how HOS focused leaders of these areas are as they develop these programs, right? Are we opening a CSNP just in effort to capture more members, to enroll more members for business reasons? Are we opening a CSNP right? Are we opening a CSNP because we believe we have invested in the resource, the expertise, the care delivery models needed to really improve health outcomes for these populations in a unique way, above and beyond what your typical MA contract can provide to folks?
Yeah, and I think I can't wait to see how it plays out. And I also think we know that the best performing CSNPs, right, are running on this dual chassis. We know that they have, a mature and well credentialed care management staff. I see a lot of CSNPs that lean into certain cardiac, credentialing for their care managers. That really super focused disease management, augmentation to the actual programs. So again, looking forward to seeing how this plays out. And just thought this was neat to see because you can absolutely see that the result of someone who is care managed, right, in these outcomes. Yeah.
Yeah, totally. Yeah, I thought this was a really interesting look and a fun look. And, you know, doing this work, seeing the disparities, seeing the data, admiring the data. This is important. It gives us like that business case to stand on. But I want to get into like, and I know folks want to hear this, like some of this so what, right? Like, let's not take this great analysis and stick it on a shelf where it can collect dust, right? What do we do with that? Like, how might we act? And this is where I just want to open it to discussion. And this is where we chatted a little, but maybe we just continue that conversation more within this forum. How do we work within a health plan to actually, where case mix adjustment stops, closing the gap, where do we step in as clinical leaders within health plans to close the rest of that gap? And maybe that's a heavy, broad topic to throw out there, but either one, Becky or Carolyn, what are some of your thoughts about how we can take action?
Becky, do you want to start?
You're welcome to start,
Okay.
and then I'm happy to.
I have, and because it's
Carolyn's
building.
like, I have so many thoughts.
Well, it's building off of something that Becky said when she brought
Yeah.
up data. We sort of talked about it and then sort of glossed over it. What I think is that, when you can serve up a specific laser focused strategy that is data driven, right, you're going to get more impact. So when we think about, right, our pharmacy data flowing, new diagnoses flowing, frequent utilizers flowing, this allows the health plan to, through whatever mechanism is available to them, right? Either you have a clinical care manager, you have a non-clinical support staff, care coordinator, someone who is able to touch that member and make sure that they have access to the services they need, they feel cared for by the health plan, heard and supported. Those are all things that at least start this. I think a lot of times we're doing blanket programs without hoping, right, for a positive outcome, but hope is not a strategy, right? And we say that a lot, right, among the three of us, but that it's the more focused you can get on the population that needs the support or is able to move, the better.
Yeah, Caroline, just to build on that, right? I often think about these types of, I'm going to call them quandaries, right? Because it's almost like you've got to step back and think about all the moving pieces, right? And then what do you do about it? And I often think about them in an improvement framework of, to your point, Caroline, the identification piece, right? So it starts with if you can't identify the populations, the drivers, right, that thankfully in the case of HOS and it being clinical, all have a lot of evidence base in them, right? And there's great information out there as to, okay, if we combine these three variables, someone may have worsening health or, maybe showing signs of decompensation, right? Using that data and that information to help identify first, right? Then based on that, what are the populations? What are the actions? Is it that, a lot of our populations have trouble with transportation, right? So not even just clinical factors, but their biggest challenge is they can't ever get to the provider. Therefore, they can't ever have that interaction, right? Or have a challenge having that interaction. Okay, how do we solve for that, right? And that may be a very tactical and specific intervention or action that frankly may not have been thought about if you didn't use the right data and information to help identify, right? Then are we measuring how the things we're doing, right? The actions we're taking, how they're working? Are they actually helping to make things better? Is it not working as well as we thought, right? Because sometimes it's a little bit of a scientific hypothesis, right, as to whether it's going to work or not work. And so are we measuring whether it's working? And then what are we doing to really try to adjust for that, right? That tactical intervention, we're seeing it's working or not working. What is that adjustment? What is that reinforcement of that activity? So I think really thinking about it that way in many cases, there are things for certain population types, right? Age groups that work kind of across the board and that anybody could implement. And then there's other things that have to be really specific to your populations, to your geographies, to what's accessible to you and your members in your particular area. And that all takes knowledge of and information about your particular populations that I bet if you talk, as a health plan with your frontline teams, they could point out a number of those things to you already.
I'm sure too. And all of that, yes, first off. And, just like towards the beginning of our conversation, we were talking about people picking, people health plans, star strategy, picking apart the membership into stars domains. Here's my HEDIS initiatives. Here's my initiatives within HEDIS HOS. And I think we've established the need to look at that holistically. The same I see happen with HOS, right? Where we're like, here's my falls group, and here's my incontinence group, and here's my poor health outcomes group. Where if we just stop and think, right, as we're transitioning members, maybe folks, whatever your stratification logic is internally that puts somebody into complex care management, which is like, acute care management program in your health plan. Yes, that's the hand gesture, Becky. This is a whole HOS package person, right? If they just had a stroke and they have a new baseline and they've come home, they're not just a physical decline risk. They're probably a mental health decline risk. I mean, it would be devastating to me. I would definitely have mental health issues if suddenly I had a stroke and hemiparesis and whatnot. I'm also probably going to now be a falls risk, right? No question. And getting to the bathroom on time and bladder incontinence. I mean, people are often a whole HOS package, especially folks that have gone, work as you're working with your internal teams to do this HOS education we've all been talking about. As you talk with the different divisions within your care management program, your acute care management folks, et cetera, this is how we bring HOS into the conversation with these folks. This is how we have a HOS-centric care management program. Yeah. All right, folks. Oh, Caroline. Okay. I do have a little cheat sheet of notes over here so I don't forget important topics. And this is a huge pivot, but I did not want to forget, and I wrote SEP over on this sheet. Those are the words I have. When this wasn't part of what we had prepared to talk about, but right before we started rolling with this podcast, you brought forward such interesting information about how we need to look at kind of what's happening in the bigger Medicare Advantage space and the way that may or may not impact STAR strategy. And then you brought it into HOS strategy. And I want to turn it over to you because I will not do it justice if I get it started beyond that.
Well, I think if I remember correctly, we were talking about the SEPs and the change in SEPs for dual members, right? Where we know that we used to have a quarterly SEP that was available to DSNP members, so they could change plans every quarter. But we know that starting the beginning of this year, right, that we went to a monthly SEP that was available to full duals, right, to go into an integrated plan or revert back to original Medicare and a standalone PDP. Okay. So with that, there was a big thought. HOS is for these outcomes measures, it's a longitudinal study, right? We've got to talk to the same person 2 years later, right? At baseline and 2 years later. So what about this membership churn? Let's think about this. And so when we looked at how, what does DSNP look like right now mid-year? And what are we finding? And so what we found is that, there's actually been a stabilization in the subset of DSNP, which is the coordinated DSNPs. Those are going to absorb the partial duals mostly, and have some full duals, but you can't enter into a coordinated DSNP outside of AEP or outside of another SEP that might be available, but not the integrated DSNP SEP. Anyhow, we've seen stabilization for that, the majority of DSNP members, but continue churn for the integrated plans. Okay, that's the ones where members can enter every month. So we're seeing a churn at 2 to 4 times the amount of the general enrollment. So that will impact, the ability for these longitudinal studies. And, when we were talking to prepare, we were talking about it actually in terms of oversampling or any kind of strategy there. So I think that may be, another part of the conversation with, do you have the same, how stable is your membership, right? How are you deploying appropriate, HOS strategies? Do you feel confident that you're supporting these members, throughout the entire year, right? As we've talked about today, gone whole HOS for your strategy, and then also, be able to realize that if you are running a a coordinated DSNP, really double down on your efforts. Those members are going to be your members, right? So, that's something to think about too. So I think that's where you were going with it, Jessica. Or is there anything else you'd like for me to talk about with this? Because again, it's my favorite topic. So.
No, I just thought that was just such an interesting perspective. And I think blowing that out of HOS, how important that we as leaders, stars leaders, quality leaders, leaders within the Medicare Advantage space and beyond, but I'm going to stay in the Medicare Advantage space because that's where I live comfortably, pay attention to what's happening from a regulatory perspective outside of our myopic view of stars, right? What else is happening out there, and how might that impact my strategy? And I just thought that was such an excellent example of that. It's a lot. There's a lot happening all the time, everywhere, all at once, right? I think there was a movie about that recently elsewhere. Regardless, I think, that's where we're here for you, right? I mean, we can be your phone a friend, folks. If it's a lot to keep track of, it's a lot just to keep track of the regular stars churn within your health plan. And feel free, if a new piece of regulation drops or federal guidance drops, feel free to use us as a phone a friend and just iterate a little more on how might this impact my strategy? Where do I need to think about this in terms of HOS or CAHPS or HEDIS or adherence?
Yeah. Jessica, I feel like we would be remiss, as we kind of try to close out here, from making sure we remind folks, right? And really come back to what we talked about at the beginning, where this is not about just a single touch point with a member, right? This is not about a single pamphlet or leaflet or document that goes out to folks. This is health outcomes are created, right, in a clinical space and in a day-to-day space with multiple activities, things that happen every day in our members' and patients' lives. And whether that is a new diagnosis or it is a new medication or something they forget that they're supposed to be doing on a daily basis, that's how those outcomes are truly created. And so we would be remiss to not think about a HOS strategy and a strategy that is trying to improve or at least maintain, based on the expectations of a population, their health outcomes if it's not thought about in the same way, right? That this is about what are those touch points, just like we talk about in the member experience space, every touch point, every opportunity that you have from a member or a patient perspective to make an impact and improve their experience is absolutely an opportunity you should take. We should be looking at that with our HOS strategy and the outcomes we're trying to create, right? And we've talked about a lot of tactical approaches and things to think about, but it also requires that your mindset, right, is shifting to a place of this is about what we do every day.
That's right.
How we integrate these things and work across our populations and with our providers and with care teams to impact those things that are happening every single day with our members and patients.
I agree. You took it to church with HOS there. It needs to be embedded in how we do business every day. So I love that. All right. Well, with that HOS amending, we'll let it go. Thank you all for joining us today. Hope that you learned something. If something stimulated a question or a thought, feel free to connect with us. Happy to help. And we'll see you all next month.
Thank you.